So for 2021, they estimate there'll be 104,000 new cases of colon cancer. 104,000. There'll be 45,000 new cases of rectal cancer. Now you ask what the difference is. So if you look from an anatomy standpoint, the rectum is the last, say 10 to 12 inches of the colon. So it's in continuity, it's the same organ, but they do differentiate it. But if you're talking about colorectal cancer, there's going to be about 150,000 new cases diagnosed this year alone. 150,000, that's enormous. They expect 45 to 50,000 people will die this year from colon cancer. Okay, that's 45 to 50,000 people, the majority of which could be probably prevented, which is an amazing number. And if you think about that, that's more people that are killed in car accidents every year. Okay. Now, if you ask what your risk is, so if you don't have a family history of colon cancer, or you're not one of the rare people that have one of these genetic syndromes that predisposes you to colon cancer, your risk is the same as mine, which is about 4% over the course of our lifetime. Now, what that means is if you line up 100 people just like you and me, 4 of them are going to get colon cancer and 2 are going to die from it. That's if we don't do a thing. That's if we don't screen anybody, okay? That's not the bad news. I mean, that's not the good news. The good news is if you screen people, you can take that 4 out of 100 and drop it down to less than 1 out of 100, 1 out of 1,000, okay? That's the impact that colon cancer screening has for everybody. So some of the good news statistics that came out of the American Cancer Society is that for the last 10 or 15 years, colon cancer has been dropping about 1% per year. 1% doesn't sound like a big number, but if you have a huge number of people to begin with, 1% actually is several thousand people per year. That's good. But this is largely due to the older population of the United States, 60-year-olds and older. What it doesn't tell us is that between the ages of 50 and 60, where we really try to get people to be screened, the incidence of colon cancer is going up 1% per year. So it's climbing. You may have also seen a couple years ago, a lot of news came out about the younger people getting colon cancer under the age of 50. And that number is actually going up 2% per year, okay? So those numbers are actually climbing. So I think what we need to do is really get the word out that people need to be screened and screened earlier than what we formerly thought of. Now, I call those numbers the views from the cheap seats, okay? So that's kind of sitting up in the, you know, the third tier of the stadium and looking way down from the $5 seats, okay? What I want to do is boil this down to some very real information, okay? The numbers don't tell the whole story, and that's what's really, what I find is a message that I have to get out to people. Rates for colon cancer are higher in African-American population and Latino population than Asians or white populations, okay? The incidence is higher. More concerningly, the mortality rate is higher in African-Americans than in whites. The survival is shorter in African-Americans than in whites. And I think there's a lot of different reasons for this, including barriers to healthcare, access to screening, and things like that. And that's why I really want to get the message out that screening is so important across the board, across the board. So I want to show you a slide. I promise I won't do a whole bunch of slides because that is the best way to lose an audience. So I want to show you one picture here. If you look at this, okay, ready? Now we tested this out earlier on sharing the screen. I'm going to give it a shot. Uh-oh. Hang on, I'm going to give it a shot, okay? Okay, bear with me. Okay. Can you all see this screen? Okay, so what we're looking at here, this number right here is the number of the incidence of colon cancer deaths. The white triangle is everybody. The blue square is white population. The green circle is African American. And you can see there's a difference here. There's a difference, and these are years down here. So year by year, the numbers are falling, but they're not down here where we want them. And even more importantly, they're not way down here where I want them. I want them really down low. But there's a discrepancy here that we can't not talk about, okay? So an important question is, why do we screen people? Why do we screen people for anything? Well, you have to think about the diseases that we screen for. We don't screen for diseases like esophageal cancer in the majority of people because it's not as common as other diseases, right? But we screen for colon cancer. So the disease must be widespread enough throughout the community that we can really make a positive impact on that disease. The disease must be serious enough, so we don't screen for sunburn because it's really not that serious, but you screen for colon cancer because it's a serious disease. You screen for breast cancer because it's a serious disease. You screen for cervical cancer, for prostate cancer, because it's serious enough to cause a real health impact for people, okay? But there has to be a long enough lag time between when the disease starts to when it becomes really harmful for somebody, because then we can intervene anywhere along this point to prevent the bad things from happening. And that's what we're talking about with colon cancer. So from when colon cancer starts as a little polyp, which are benign, and some polyps, not all of them, but some can turn into cancer, that takes about 10 years for that to happen. That's a long time. Mm. So if somebody pops up with a polyp, if we do a colonoscopy, anywhere up to that 5, 8, 9 years, we're going to be able to catch something before it turns to cancer, before it has a chance to spread and cause real disease, okay? Oops, there we go, okay. And we also really, most importantly, we have to have tests that are widely available for people so that the population as a whole has access to cancer screening so that we can get the entire population screened, okay? And it has to be safe, obviously. So we can't subject people to an unsafe screening test. And the thing is about colon cancer is that that fits all those criteria. It's a widespread disease, it's a lethal disease, but we have safe, effective ways to screen for and prevent colon cancer from ever happening, okay? There's a light right above my head that if I tilt my camera back too much, it's gonna look like I have a halo. And we know that is not the truth. So, what do we talk about when we talk about screening tools? Now, I'm not going to ask for a show of hands or anybody, but for all of you, think about if you've been screened. Good for you. Think about if it's time for your screening, and how you were screened and how your physician suggested you actually went about getting screened to prevent you from getting colon cancer. Now, the best test, and the one that I'm going to talk about today, for the most part, is a colonoscopy test, okay? I turned 50, and that's what I did the month I turned 50, because you know, if you do this test for a living, how many people actually say to you, well, have you had the test done before? So if you're 50 and you haven't had the test done before, I couldn't hide behind the fact that I'm not old enough to have the test after that. So I went and had the test done. So full disclosure, I did have the test, okay? So what I want to show you, a lot of people who haven't had a colonoscopy are afraid of it. They're afraid of the unknown. They're afraid of procedures that they don't know much about. A lot of people have this misconception about the size of the colonoscope, and that's, you know, that really is a very fair concern on people. But lucky for everybody, I have one here. And God, I hope it's clean. No, it's clean. I'm kidding. It's clean. But this is the size of the colonoscope, and you can see it's thinner than my pinky is, okay? It's very flexible. You can tie this thing in a knot if you wanted to. I'm sure they don't want me to. But this is what we use to do the procedure. And if you can see on the tip, there's a little channel that we can pass instruments through. There's 2 really, really bright headlights. There's some other things on here that actually go to help us use this tool to help screen people, okay? The highlights of a colonoscopy test is, this test is very safe. It's very safe. The complication rate is extraordinarily low. If you talk to enough people, you may find somebody who knows somebody who had a complication, or you may know somebody that had a complication. And that's a very powerful tool to keep people from getting screened if they hear these things. Realizing, though, the complication rate is extremely, extremely low. Extremely low. It takes about 20 minutes to do the whole test, start to finish, 20 minutes, and then you're done. And the nice part about it is in the vast majority of the country, you're going to be given some sort of deep sedative to make it comfortable for you. Okay. This test can be done unsedated. I don't recommend it, just because there are some things in life that are worth remembering, and this ain't one of them. Okay. So make sure you get a nice sedative for the procedure. It makes it go so much smoother. I can't tell you how many people were really nervous about the test. And when I'm speaking to them after it's over with, they said, well, when are we going to get started? And I'm like, it's time to put your pants on and go home. You're done. So it's a very, very comfortable test. The details about this is it does require preparation at home. So, you know, the day before the exam, people have to drink some medicine to cleanse the system out in order to have this test done. And that's really what people associate with who've had the test as being the least pleasant part of the whole exam. People who've had the exam say the test is nothing compared to the prep, but the prep is so important, because the better prep that you do at home, the better the exam will be. Now, just a little detail, it's usually one day. It's usually, we keep people on clear liquids all day, which is broth and jello and juices and lots of water to make sure that you stay hydrated. And then a laxative medication, and there's multiple ones on the market, but something that's going to really literally just rinse your system clear. Okay. And that's important, because when it's clear, we can get a really good exam, and we can find little tiny polyps that aren't going to cause a problem this year, the next year, 5 years, but 10 years from now might. So we take them off when we find them. Okay. So a lot of people ask me, when do we start screening? If you don't have a family history, the best time to start screening is when you're 45 years old. Now, you heard me say 50 a couple of years ago, a couple of minutes ago, but that age was changed to 45 by the American Cancer Society about 2-3 years ago. And we're really stressing that people start to think about their initial colonoscopy younger, because like I said before, the incidence of younger people getting colon cancer is actually climbing. Okay. So we want people to come in earlier than the recommended age of 50. Okay. So don't be shy. Ask your doctor if they haven't suggested. If you're 45, say, listen, you know, I heard this guy talk the other night, and I don't know if he knew what he was talking about, but he said 45 years old is when I should come in to get my colonoscopy. And that's really the right age to get screened. Okay. So remember, and the nice thing about this screening test is it's done once. And if you don't have any real risk factors like family history, or you don't have a lot of polyps, you may get 10 years before you need your next one. That's a nice long period of time to not have to worry about a 20-minute test. But if you compare this to other cancer screening, like breast cancer should be done every year, prostate cancer should be done every year. You know, this is done at the very most, 10 years. Some people we have to bring back sooner, but for the most part, you can go a long time without having to think about it again. Okay. So that's the colonoscopy. Does anybody have any questions about that test in particular? Any of the details about that test?
Yes, I have a question. If I'm so sorry, I might have jumped in a little late and missed the answer, if it was already asked. If you're not at that age, but you're presenting with certain symptoms, kind of just go ahead and get it done, right?
Absolutely, absolutely. So if you're screening assumes that you're asymptomatic, you don't have any symptoms whatsoever. But if you're 25 years old and you're experiencing bleeding, or you have an abrupt change in your bowel habits or something else, you know, your doctor may suggest, well, let's get a colonoscopy to detect and see what's going on. And that's totally, totally reasonable. And I tell people, even though technically it's not screening, if they come in when they're 25 or 30 or 35 with a problem, I tell them at the same time, it's going to double for a screening test. So if we find anything like any polyps, we're going to take them off right then and there. But you're absolutely right. Don't be shy about asking your healthcare professional, your doctor, your nurse practitioner, whatever. If you're having any symptoms, listen, shouldn't this be checked out with a colonoscopy? Okay.
Yes, thank you.
Absolutely.
I had a quick question. I just wanted to know, why is it set at 45? Like, why wouldn't it be like 25 or 30 to cut down the rate of, you know, catching it in time if someone does in fact have cancer? Why wouldn't they lower the age limit? I mean, I've had 2 in my lifetime, and I'm 65. And he
Right.
said, I said to my doctor, Dr. Mercogliano, I don't know if you know him from Lankenau,
You know,
but I said to him,
yeah,
yeah, I said, I'll see you, I guess, on, you know, the next one. He said, oh, no, you won't see me. I'll be retired. I'll be retired. He said, but, you know, in 10 years, I'll see you in 10 years.
Yeah.
So, you know, I was just wondering, why isn't it lower? You know, so I would think the rate would go down.
That's a great question. And that's the issue is really a big balance between the number of people who show up with cancer at certain ages. And colon cancer is extremely unusual in a 25 or 35-year-old person, extremely unusual. Have I seen it? Yes, but very, very uncommonly. So when they're looking at, you know, insurances and Medicare and everybody, what are we going to pay for in terms of screening tests? They look at that very seriously. How much is it going to cost if we change the age from 50 to 45 versus how many lives are we going to save and how that's going to impact? And it's a very cold way to look at it, but that's the way policy is made, unfortunately. But luckily, you know, there's a lot of people who are saying, listen, colon cancer is not getting, you know, going up higher in older individuals. It's going up in younger individuals. And that's why they shifted from, they looked at age screening people at age 40, 45 and 50, and they found that 45 was really the right age. Now, back to the last point, if anybody is having any symptoms, by all means, you know, you check it earlier because you don't want to miss something. There's a commercial on locally in South Jersey on MD Anderson, and there's a woman on who had colon cancer, and she's 38 when she was diagnosed. And she was my patient, and she's enormous strength, unbelievable strength. But she came in with some very vague symptoms, and I thought, well, you know what? Let's just check it out to make sure there's nothing. And sure enough, she had a extremely large colon cancer that required surgery and chemotherapy. And 6 years out, she's living perfect and doing great and just extremely healthy. So she's really inspirational to people who need to come and get an exam done. If you live in the South Jersey area, you may have seen her commercial. She's a really cool cat. Cool.
What are some of the symptoms?
Symptoms of colon cancer?
Yes.
You know, that's the scary thing about it, because a lot of people, when they have very early colon cancers, they don't have any symptoms at all. If some of the symptoms are very vague and they're not specific for colon cancer, meaning they can happen with a variety of other things. I mentioned bleeding before, and if somebody has some rectal bleeding, that can most commonly is from, you know, someone that's strained and irritated a hemorrhoid, which is a vein down at the bottom, and that's why they're bleeding. Or they may have inflammation or colitis, but it's not cancer. But bleeding is a very important reason why people should get tested. If people have changes in their bowel habits, if people have pain in their abdomen that doesn't go away or is persistent or getting worse, and other things, if people are starting to lose weight unintentionally, that's usually a very alarming sign to us. Or if on routine blood work, somebody is found to have low blood counts or anemia and no good cause for it. These are all reasons why at any age, we tell people come in and get checked to make sure. Yeah, those are good points. I may say some stuff about that later on too. If I'm getting redundant, just let me know. Lord knows I talk too much anyway, so okay. So
good information.
Thank you. So some of the other tests that we can use besides the colonoscopy test, there's a lot of other tests at our disposal. So your doctor may say, listen, I don't want you to get a colonoscopy. I want you to get this test called a Cologuard test. Now, you may have seen on TV the ad for the Cologuard test. It's the silly little box that walks along and talks to the person as they're, I don't know where they're going to come up with this stuff, but that's the Cologuard test. Apart from the commercial, which I'm not a fan of because it's a silly commercial, I am a fan of that test, and I'll tell you why. Because it's an easy test to do. Literally, the company sends you the box and the kit. You submit a sample. You put the lid back on, you close the box back up, you call the company, they come to your door to pick it up and take it away. You don't have to do a thing. Now that test is really good. It's actually, you know, to get uber nerdy on everybody, it's actually a multi-targeted DNA test. So it checks for proteins and genes and blood and anything that a polyp could shed without you even knowing it. And it picks up all this information based on a stool sample that you supply to the company. The test itself is very sensitive, meaning that if there's something there, that test will pick it up, okay? And the sensitivity is about 90%, which means 90% of the time, if there's something inside your colon that shouldn't be, like a polyp or, God forbid, a cancer, that test will pick it up. And that's very important, because a lot of people don't want to come in for a colonoscopy for a lot of different reasons. But if the doctor says to you, well, listen, let's do the Cologuard first. Now, if the Cologuard is negative, you don't need that test again for 3 more years, which is great. But if it's positive, that's when they say you really do need to get a colonoscopy, because there's a high likelihood there's something in there, whether it's a polyp or something else. You need to go get that checked. So I like that test. I think it's really good. Some practices, some internal medicine practices or primary cares, they don't have good access to gastroenterology, which I am, or a colonoscopy access center. So they'll offer the Cologuard test, and that's a very good way, because honestly, the way I look at it, anything that gets people screened or thinking about this, I'm all in favor, 100%. There's some other tests that are out there. There's a test called a FIT test, F-I-T, and that really just detects blood. So the Cologuard tests a lot more substances that a polyp may shed, but the FIT test only picks up blood. It's easier. Excuse me, it's not easier. It's less expensive than a Cologuard test, but if your coverage covers all that, ask for the Cologuard. It's a better test. But if it's negative, you don't need that again for another 1 year, not 3 or 10, just 1 year. But again, if it's positive, that's a reason why your doctor says, okay, well, now you actually need to go get the full colonoscopy test. Okay. There are some rarely used tests, like a barium enema. You may have remembered that test, hearing that test. That's been around forever and ever and ever. And back in the day, that was a pretty good screening test for colon cancer. But that test is hardly used at all anymore for cancer screening. It's really fallen out of favor because we have such better tests to provide people. Okay? So those are the tools we use to screen people for colon cancer, okay? Now, there's some exceptions. I talked about the age for screening. So if you don't have any other risk factors, really age 45 is the best time to start. That number may change as more information and more data and the population gets more involved with clinical studies. That number may change. You don't know. So Ms. Nira may be 42 at one point. You know, we just don't know. But right now, 2021, it's 45 years old. Now, there are some exceptions to that 45-year-old range, okay? So let's say, you know, thankfully, like me, I don't have colon cancer in my family, but I know a lot of people that do have colon cancer in the family. So it's important to know your family history. And I know a lot of times as generations go by, a lot of generations didn't like to talk about their health. We have to get over that. We have to get over that. We have to talk to people. We have to find out what diseases grandma had, what diseases your dad had, your mom had, your uncle had, your cousins have. We have to get over the stigma of that, because we're using that family history as a tool to protect ourselves against colon cancer and a lot of other diseases, okay? So let's talk about family history. There's a lot of differences in family history, right? So if somebody's grandmother got colon cancer when they were in their 90s, that's a lot different family history than if somebody's twin sister got it when they were 35, right? They're both in the family, but it's a vastly different risk for people depending on what the family history is. But as a rule, what we suggest to people is if somebody who is a first-degree relative, that's your mom, your dad, your brothers, your sisters, and unfortunately sometimes your children, those are all first-degree relatives. If they've had colon cancer below the age of 60, then your age doesn't start at 45, it starts at 40, okay? But because it's a little bit of a higher risk. Now, I said my risk is 4% because it's not in my family. If you do have it in your family, it may go to about 6 or 8%, okay? If you have multiple family members, it can go even higher than that. So again, talk to people, see what your family has in your family tree, okay? Now, let's say somebody had colon cancer when they were like this woman on the commercial, Miss Donna. She had colon cancer when she was 38. Okay, that's insanely young to have colon cancer. So when do we screen her kids? Because she has 3 kids. And when we screen them is we take 10 years off from when she was diagnosed. So she's diagnosed at 38. We take 10 years off, and we're going to get her kids in for screening when they're 28 years old at the very latest. So what we call it is 10 years below the index case. So if mom had colon cancer at 40, the kids have to come in at 30. That's the screening. And unfortunately, when we see it start to hit multiple generations, a lot of times people haven't had that family history, brought their family history out to their doctor. So their doctor doesn't know when they're 30 to say, listen, your mom had colon cancer when she was 40. You need to get your colonoscopy now, you know? So get your family histories and talk to people about that, okay? A much less common reason that people come in at an earlier date for colon cancers is because of a genetic reason, okay? The majority of colon cancer that we see is what we call sporadic. Bad luck, by chance, whatever you want to call it. Technically, it's called sporadic colon cancer because we didn't know, you didn't have a family history, you didn't have a risk factor, it just hit you, okay? And that's the majority of colon cancers that we see. The smaller percent is family history. So if a family member had it, that's a higher risk. Even a very small percentage of people come in with genetic risks. And these people are either carrying a cancer gene or they're missing a cancer protective gene. And the body's amazing. It has genes in there that actually are immune to fight, or they're programmed to fight cancer cells. So if a cancer pops up, that gene turns on and kills the cancer cell before it can get a hold of you. I mean, it's an amazing system. But if there's genetic mutations in any of these genes, then we screen people very, very early, like in their 20s. And a lot of those folks, that's where you hear people have to come in every year for a colonoscopy. So we run a genetics clinic here, and I have a whole bunch of families that come in once a year for their colonoscopy test. So, and they're all good sports about it, thankfully, because trying to talk someone into a colonoscopy once is a hard enough deal. Trying to talk them to come in every year for a colonoscopy, I should sell used Pintos, man. That's what I'm saying. So are there any questions about screening or screening tools that we can talk about?
I have another quick question. I'm sorry, but
No,
I have a friend who he tells me he doesn't have colon cancer, but he has a port and he's getting chemo because he has a tendency to have polyps all the time. So he goes once a year. So I've just been saying prayers for him, but because when I hear chemo, I think of cancer, but he's telling me, no, it's a preventative, whatever, I guess, course of medicine, for lack of a better word, that he's going through. So he gets it like every week. It's delivered to his house. Nurse comes, gives him, and then the next day he feels yucky. And then, you know, but I feel that he's got, I mean, is that normal or is that, I mean, for him, he's okay.
No.
All right. So he's in denial then, maybe.
Well, he might be trying to protect you from what he knows, you know? So it's, listen, it's tough to talk about. It really is tough to talk about.
I recommended that he try turkey tails. Like I'm all about homeopathic and natural stuff. I don't know if you've heard of turkey tails, but it's on TED Talks. It's a mushroom that cures cancer, that, you know, it's helps you, it's preventative, and over a period of time it can, you know, eradicate, you know, a lot of things that go on in your body. So I figured maybe he should try that, or a holistic diet, macrobiotic, whatever, but he's like in denial. He won't do it.
I have a question too, Dr. Deitch. I know a woman, she had uterine cancer, and she told me that's on the same genetic pool her father had colon cancer. Is that true?
Right. Well, yeah, that when I hear that story, I think of a syndrome called Lynch Syndrome, which is where one of the proofreading genes in your DNA is faulty. And in people who have Lynch syndrome, they're subjected to risks for colon cancer, endometrial cancer, stomach, bile duct, pancreas, small intestine. I mean, lots of different cancers, because your body's lost one of the tools it has to protect you against it. But she's right. So a father with endometrial, oh my God, a father with endometrial cancer. You're going to say, go get the degree from Hahnemann and show everybody, because I don't believe you after that. No, a father with colon cancer and a daughter with endometrial cancer.
No, uterine cancer. Is that the same?
Yeah.
Okay.
Similar parts. So uterine cancer and colon cancer are both at risks for that syndrome. And those people usually have to come in every 1, 2 at the very most every year for a colonoscopy.
Okay.
Yeah. So yeah, that's one of those exceptions. Now, if somebody has had somebody who has had uterine cancer, like maybe an aunt has had uterine cancer, but there's no other cancer in the family, that really is not a risk for relatives to have colon cancer. Okay.
Mm-hmm.
But again, it's so important to talk to your doctors about your family history. It's so important. A lot of doctors are pressed for time, because they're packing more people in and that sort of thing. But when you go to your family doctor, you have to tell them, this is my family history. And knowing my family history now, what can you do to protect me against these diseases that have run through my family? That's a very legitimate question to ask somebody.
Okay, so I have a question.
Yes, ma'am.
So for one of your family members has had colon cancer,
Yes.
say your father or your mother. What are for the children? How does that break down? Or an aunt, your father's sister,
Mm-hmm.
or your mother's sister,
Right.
if they've had it. How does that?
So that's a great question. So if it's a first degree relative like your mom or your dad,
Mm-hmm.
if it's 60 or below, then you start at age 40, or 10 years younger than when they had their cancer. So if they had it at 52, you would start at 40. But if they had it at 46, you would start at 36. Whenever I hear
10 years when you're,
yes, you go back that many years to get screened.
right.
When somebody comes in and says an aunt or an uncle has had colon cancer, then I always ask whose brother or sister that was. Was it your mom or your dad's? And how is your mom and how is your dad? Have they had any diseases? Like if your aunt had colon cancer and that's your mom's sister and your mom had polyps, I kind of think, well, that family is prone to developing these polyps, which potentially can turn to cancer. So yes, we'll screen you a lot sooner and a little bit more readily, So normally, if you don't have any family history, you can go 10 years without having another colonoscopy. But if you have a family history, we shorten that to 5, just so that your higher risk doesn't translate to a more prevalent disease. Okay. I hope I answered that. Okay. Did I answer that? Okay.
Yeah, very good. Thank you.
All righty. So you've all got screened now. Great. So let's say you go to your doctor and you wake up from the procedure and you ask them when it's going to get started, and they tell you you're already done. And they tell you, we took polyps out. Because a lot of people have heard, well, you know what? My doctor said they took polyps out. What does that mean? Well, first of all, take a breath. Polyps are benign. Polyps are benign. Polyps are benign. Okay, they're not cancer. But some types of polyps actually, if left alone, have cancer potential. They can turn to cancer 10 years down the road. That's a really, really long time, because polyps grow very slowly and they grow very quietly, which is why when you're feeling well, when you're feeling fine, that's the perfect time to get your test done. You don't want to wait till you're not feeling well. You want to get the test done before symptoms arise, okay? Because what we're looking for when I do the test is we're looking for these little polyps, these little growths in the colon that we can remove. And if we're able to take these polyps off when they're little, then that polyp has 0 chance of turning to colon cancer, 0. So we've taken your risk of say 4% over the course of your lifetime, like we talked about earlier, and we've dropped that down to less than 1 out of 1,000, okay? Or even less than that. That's what we like to do. But some polyps have zero cancer potential at all, zero, none. So when we take a polyp out, we send it off to the pathology lab, and they look at it under the microscope, and they can tell us exactly what kind of polyp there is. And there's probably about 4 or 5 different, I was about to say flavors of polyps, but this is, you know, not from my days of working at Baskin Robbins. That's not that. So there's 4 or 5 different types of polyps. And some have actually zero cancer potential whatsoever. So if we take those out, we can say you had polyps, but they had absolutely no risk for you, and you get the full 10 years. Conversely, we've taken polyps out where they're higher risk, and we say, well, we can't give you 10 years because you've had polyps. We have to go to 5 years or 3 years, or sometimes even shorter than that. So that's the question to ask. When they take polyps out, be sure you ask your doctor, what kind of polyps were they? Let me know when you find out, and let me know when my next colonoscopy needs to be, because I want to mark that down. I don't want to miss that date. I don't want to be a year, 2 years, 3 years late on that date, right? Perfect. So I'm going to try again to show some pictures, okay? I promise you I wasn't going to kill you with slides, but whoops. Hang on a second. Bear with me, okay? All right, so. Okay. Can everybody see this okay?
Yes.
Okay, so this is your colon. Well, it's not your colon, but it is a colon, okay? This is what a colon looks like. So you can see my arrow here. These little white things are just reflections off the headlight on the scope, which is really, really bright. But this is what a normal colon looks like on the inside. It's got this kind of triangular shape. There's lots of little folds for things to hide in, like polyps and so forth. So as a colonoscopist, you know, we like to get up in all these little folds and see everything. So it takes about 20 minutes to see the whole thing, okay? So I'm getting the hang of this. I'm glad my kids aren't around to see me fumble through this thing, but, you know, at the same, because you know how kids can be, right? Okay. So when we're doing an exam, we're looking for things like this, okay? So you can see the red arrow here. So all this over here is normal colon, but you can see this lump right here. You see that lump right there?
Yeah.
Okay, so that's a colon polyp. That's what a polyp looks like. So we're looking for these things. That's a pretty decent sized one. That's probably about 5 or 7 millimeters across. Not quite a jelly bean, maybe a little jelly bean, okay? But we want to find that because that to me looks very benign, okay? So what we do when we find them, we don't stare at them. Well, for a minute we stare at them, but not that long. But what we do is we take them off. Can you see this?
Yeah.
Okay, so that's a polyp right here. This white thing right here is what's called a snare. So it goes through the channel of the scope, and we pass it through there, and it opens up like a big loop on the end, and you kind of lasso it, okay, cowboy style, and then you cinch it up really tight, and you can actually put a current through there, and that'll cauterize and take that polyp right off. Now everything's bigger on TV, so this snare right here, the width of this white snare is the width of a coffee stirrer that you get at Wawa, okay? They're really small. So just judging by the size, that's not even a centimeter. But that's how we take polyps off, okay? And the whole reason that we take polyps off is because we want to avoid this. Okay? This looks a lot different, doesn't it? So you really can barely see any normal colon in here. This is what colon cancer looks like, okay? And that, remember that big triangular opening I showed you earlier? That's what's left of it, okay? So that's nearly obstructing. So I imagine people may have had some symptoms with this. You can see it's bloody a little bit down here. I don't mean to show gross pictures, but I think it drives the point home
Yeah.
because you don't want this growing inside of you, right?
Mhm.
I don't want it growing inside of
Yeah.
me. Take it off, get it out.
Mm.
So if you get tests somewhere, you find those smaller polyps and we can take them off fairly easily, then that prevents that progression to that horrible looking thing I just showed you, okay?
Mhm.
I probably owe you a picture of something nice. I'll see if I can find my dog in there. He's kind of cute. I'll show you that later on. If we have time, I'll show you that. He's a putz.
Wow.
Anyway, okay. So that's generally, you know, what we wanted. That's the whole reason why we wanted to get people in to get screened, so that we can find those polyps, which are more prevalent as we hit our 40s, 50s, definitely 60s, 70s, 80s. That's why we want to find them and take them off right then and there, okay?
Mhm.
So we talked about some of the symptoms that even if you're in between your screening, let's say you got screened when you were 50 or 45, and let's say 50, and you're now 53, and you didn't have anything going on when you were 50, no polyps, no family history, nothing. Your doctor says, I'll see you in 10 years. But you start to have bleeding, right? Or you start to have pain, or you notice a change in your bowel habits. Chances are overwhelmingly, it's not cancer, overwhelmingly. But I'm not one to play the odds. I'm one to say, you know what, let's just find out for sure. So you're 3-4 years out from a colonoscopy, and I know I promised you 10, but now there's something going on that I want to make sure that you don't have any issues going on, okay? Because there's a condition called interval colon cancer. That means you develop colon cancer in the interval between your screening tests. And it's a real entity. So we want to make sure that even if people have been screened, if they have any kind of symptom that they're concerned about, don't be shy. Go to your doctor and say, listen, I know I had a colonoscopy last year or whatever, or 2 years ago or 3 years ago, but I'm having something new and I want you to check it out for me, okay? So those signs and those symptoms are really, they're not specific for colon cancer, thankfully, but at the same time, if you're having anything that potentially could fall into that spectrum of symptoms or signs, get it checked, okay?
Mhm.
Are there any questions about screening or anything like that?
Doctor, what causes the polyps?
Miss Garnett, is it Miss Garnett?
Yes, Vita Garnett. Yes.
Miss Garnett, if you find out, let me know. Because we just don't know. Some people are predisposed to developing polyps if they have certain medical conditions, but the majority of us are not predisposed. They're more what we call sporadic, so they'll just kind of develop.
Okay.
And they're common enough. So if you take, you know, if you do 100 colonoscopies, we tell people to be, you know, the people that I'm training to be endoscopists and colonoscopists and GI, I say, you keep track of how many polyps you find in your screening tests. And if you're only finding polyps in 20% of people, you're not doing a good enough test. We should be finding them in about 30-40% of people, maybe even more. So when people come in for a screening test and they have a little polyp, I say, don't worry. This means we did a good exam. We got what we came for, to make sure that you got screened. I feel much more comfortable finding something than kind of making sure that there's nothing, and making sure there's nothing there. But polyps form for a variety of different reasons, but we haven't figured out why they form. So we can't specifically tell you what to do in your lifestyle to change that.
Okay.
So until we figure that all out, we tell people, make sure that you do the things you can do, but definitely get your screening test.
Thank you.
That's a great question.
Mhm.
Anybody
I
who
have
wants
a question.
Okay, but anybody who has a question that has the telephone, you have to put your phone on *6. Anybody that wants to ask a question and you are on the telephone, *6. Go ahead, whoever else had a question.
Did you hear me?
No, go ahead, Pam.
Okay, because I don't have it on *6. Okay, if you had a screening, colonoscopy that was negative and kind of went past the 10 years, but did have a fit test later on that was negative, should you still go back and get a colonoscopy?
If you had a fit test, then you're good and it's negative, you're good for a year with a fit test. So you don't have to have anything else done. We tell people the fit test and the Cologuard test, which are those stool sample studies. People with strong family histories or anything like that, that's not the right test for you. You really need to get a colonoscopy. But the fit test and the Cologuard test is really a good test for people who don't have a family history. And your doctor may say, well, let's get the FIT test or let's get the Cologuard. And if it's negative for the FIT, you get another year and then make sure you do another one. Or for Cologuard, if it's negative, you get 3 years and then make sure you do another one. Okay. But you don't necessarily need a colonoscopy, especially if you're completely asymptomatic and your FIT test is negative. So
Thank
good.
you.
I'm glad you got screened. Good for you.
Hey, how you doing? Does polyps alone cause bleeding, or would it be other symptoms contributing to the bleeding?
That's another great question. So when polyps are small, like the little one I showed you on that picture, if somebody's having bleeding or they're anemic, where their blood counts really have fallen, I find a little polyp, I'm not really comfortable saying that's the reason why. So we'll keep looking for other reasons. But if we find someone who has had a couple little polyps and some internal hemorrhoids that look very angry, that's probably a good enough reason. But it's good enough as a segue or a reason to come in to get your test done in the first place. Okay, so if somebody has bleeding, I tell people, listen, whatever age you are, it's okay. You have blood coming from somewhere blood shouldn't be coming from. Let's check it out. Let's make sure everything's okay. Be on the safe side.
Okay, thank you.
You're welcome. You're welcome. Alrighty. So the other thing, one of the things I want to talk about today is barriers to screening, and it's something that really is very impactful for me in our practice, especially practicing in Camden, New Jersey, which is it's a city with a lot of different ethnicities, a lot of different language barriers, a lot of different access to healthcare, a lot of limited access to healthcare. So differences really do exist, and they exist geographically. Like I talked about with Philadelphia and the suburbs of Philadelphia, they differ by ethnicity. And I think that graph I showed you earlier with the discrepancy between colon cancer deaths going down and colon cancer deaths in African-American population going down, those graphs aren't right on top of each other. There's a separation. So there's a difference between screening that we have to fix. So some of the facts: the incidence of colon cancer is higher in African-American community than any other ethnicity. And that's one of the reasons why we should be very vocal about going into communities and getting people to demystify screening in any shape or form. The death rates are higher. African-American population are more likely to have colon cancer discovered at a later stage, meaning it can't be treated as effectively as someone who had cancer detected at an earlier age. Okay, there's less options in order to cure them from the disease. And something that I think is very important and impactful for us to understand is that African Americans versus other ethnicities in the United States are less likely to be adequately screened to prevent colon cancer. And in one study that I read, which was shocking, African Americans are 1/3 less likely to be offered screening. And that's a shocking statistic. But it was from a study that looked at major metropolitan areas. So it's real, and we can't overlook the fact that this is something we have to fix as a nation and as a community of healthcare providers. Now, this varies between physician to physician to physician. So a lot of times, like, I'll see a lot of different things in my office besides colon cancer screening. So if somebody comes in for a liver problem and they're 50, I'll ask them, have you ever had a colonoscopy? And if they say no, guess what we're going to do? In addition to fixing your liver, we're going to get your colon cancer screening test. When you go see a family doctor, they should ask you these things. What's your family history? What are your risks for breast cancer? What are your risks for colon cancer? What are your risks for prostate cancer? And let's get you screened based on, the recommendations for what age you should be screened at. So it might be 45, it might be 40. But don't be shy about asking. If you go in to see your doctor and they didn't talk to you about screening, simple question: am I up to date on all my cancer screening? For a man, am I up to date on my prostate cancer screening? And am I up to date on my colon cancer screening? And if the answer is no for either one of those, let's get that checked, okay? Now, interestingly enough, there were 2 pilot programs. One was in New York City and one was in the state of Delaware, where they looked at that discrepancy between ethnic groups and their rates of colon cancer. And they really invested a lot of time and money and effort to try to fix that, going through primary cares, access to screening, public service announcements, everything. And what they found is within a year's time, that gap shrunk down to nothing. This is amazing. So it takes some effort to get people in the most vulnerable or the most vulnerable populations for healthcare and diseases to get those folks in to get screened. There's a lot of reasons why people don't, you know, the vulnerable populations don't get screened. They don't get screened for obesity. They don't get screened for blood pressure, for cholesterol, for diabetes. All these things need to be talked about with your doctor. So again, don't be shy about asking. A lot of people are afraid to get a colonoscopy. I'm not asking for a show of hands, but I'm sure that if somebody was suggested to you, listen, you're 50, you got to go get a colonoscopy. A lot of people think immediately, there's a lot of reasons why I don't want to go kicking that guy's door down to get this test done. You know, there's a lot of reasons why I want to stay out of that office. So we can't force the test on you. We can suggest to you, let's get the test done. But I think that good communication and asking all the questions really helps people come in for their test, okay? Very, very uncommonly will I have somebody just dig their heels in my office and say, there's no way you're doing that to me. That sounds kind of horrible when I say it that way. I didn't mean it that way, but that's essentially, you know, there's no way I'm getting that test done. But usually with, you know, answering all their questions and even bringing things up that they may not want to ask. And I think fear is a big reason why people don't want to get screened, right? There's fear of finding a cancer. As hard as it is for me to kind of wrap my head around that, that is a very real fear. People don't want to come in for colon cancer screening because they're afraid we're going to find a colon cancer. And it's hard to rationalize getting from that, but it is a very real fear. So we tell people, listen, if you're not having any symptoms and you're here for a screening test, the chance of us finding a colon cancer is really very, very small. So we're not looking for cancers. We're looking for polyps, those little buggers that I showed you in the earlier picture that we can take off and right at the time of the colonoscopy. So it's one-stop shopping, you know? It's like Target. You get everything you want in Target. It's like a colonoscopy. It's one-stop shopping. You come in to get screened and get your polyps removed at the same time. And that's the thing, is like I said, so there's 40% of people that come in, have no symptoms, no family history, should have something or in that ballpark, okay? You get a polyp removed and poof, the risk for your colon cancer drops dramatically, okay? Some people are worried about complications, right? From tests. This is an invasive test, it is. Your colon, believe it or not, and this is what really, my fellows, when we go to do colonoscopies in the operating room, when they have the person open and they're actually looking for us to localize something, the fellows are amazed because when we're looking in, we can actually read the numbers of the scope through the bowel wall. That's how thin it is, okay? But despite it being that thin, it is extraordinarily strong. So the risk of having a complication like puncturing the colon or making the colon bleed to the point where you have to come back for care at the hospital, those risks are less than 1 in 1,000. They're even smaller than that, but they're far smaller than the risk of actually getting colon cancer. So when you look at the balance there, the risk of a complication is far, far lower than the risk of developing cancer. And that's one of the points I bring home to people that are worried about, you know, is this test going to potentially, could it hurt me? A lot of people are afraid of it's going to hurt. They think it's going to hurt, right? But I didn't feel mine at all. And the majority of people that we do the test and they don't even flinch when we're doing the test. You know, there's a nice sedation associated with it. It's a slow test. It's a deliberate test. So we try to make sure that your comfort and your dignity from the minute you walk into the office to the minute you walk out of the office is preserved. So a lot of people, when they wake up, they don't have that sensation that they had a painful test done at all, okay? It's one of the least painful things that you can go through. A lot of people are worried about the cost of the test. And as a screening tool, whether it's a Cologuard test or a FIT test or a colonoscopy, healthcare providers are really, they're emboldened to actually provide this service for you, okay? So if you say to your doctor, you know, I don't want to, get stuck with a big bill from a colonoscopy, if you have healthcare, it should cover the vast majority of the colonoscopy procedure. Now, a lot of people, especially in Camden where I work, or in other populations of inner cities, they don't have any healthcare at all. They don't have any coverage whatsoever. And it makes people shy away from coming to the hospital because hospitals are expensive places, right? They're really expensive places. Hospitals, depending on the county, counties have programs that are structured to help people who have no income or no source of healthcare to get screened for prostate, colon, breast, uterine cancers, cervical cancers, okay? So again, if you know somebody that doesn't have any coverage and they're shying away from getting a procedure done, or if they're undercovered, have them reach out to their local hospital and see what programs are in place to help them overcome that barrier. That's a huge barrier that we need to overcome, but a lot of communities have these programs in place that allow you to get tested at no cost to you whatsoever, okay? A lot of people don't understand like the specifics of the test. Some people want to see what the scope looks like. A lot of people say, don't show it to me. I don't want to know. If I see it, I'm running away kind of thing. But for the most part, you know, just explaining like we talked about earlier, how we actually do the test, how you prepare for it, how you get ready for it, and what to expect when you come in for your test and when you leave. A lot of people don't want to get screened because they feel fine. People come in all the time and say, I don't need to be screened for cancer. I feel fine. That's the right time to get screened. Because if you don't feel well, if you're having a problem like weight loss or pain or anything like that, it worries me that we miss the opportunity to protect you from that disease, okay? So if you're at the right age group and you haven't been screened, even though you feel fine, please jump over that hurdle and come in, okay? Because that's the right time to get screened, okay? So, any questions about barriers to screening or access, anything like that?
I just had a quick question about like how, like preventative measures. Like my doctor told me you never take Senecot. I mean, you can take it, but don't, like he said, I recommend not doing it if you can help it. Rather you take prune juice or eat prunes or something with fiber, because your body can get dependent on Senecot. But when I went to a nutritionist, the nutritionist I go to told me to take 2 magnesium every night and I'll be regular for the rest of my life. And it's been great ever since.
Yeah, magnesium's a laxative. You know, like milk of magnesia is a laxative that we use. And it's actually a really safe one. You just wouldn't want to use that if your magnesium levels are high to begin with, or if you have kidney problems, because your magnesium can get too high. But yeah, magnesium is a really good bowel regimen. And I'm going to talk about prevention, what we can do. Were you peeking at my notes? Is that how you found? Is that how you found? So I'm going to talk about that in a second. So you guys are great. You're asking awesome questions. So something that one of the worst conversations you ever have to have with somebody is when they wake up, you have to tell them, listen, I found something in there and I think it could be cancer. It's a horrible discussion to have with somebody. But we have to, this the nature of what we do, we have to have that discussion with people. So what do you do if you're diagnosed? Now, right off the bat, half of colon cancers we find can be cured with surgery alone. That's it. You take it out, you're cured. Okay? So the survival statistics on colon cancer, and in fact, a lot of different cancers, is really, really climbing as we get better and better about treating this. But again, remember, the whole gist of the talk is we don't ever want to get to that point. But what do we do if your doctor says to you when you wake up, you have colon cancer, okay? People don't hear anything else after that word, right? If you hear the word cancer, your brain shuts off. You don't hear what's going on afterwards, okay? You have 2 doctors to see after that, just 2. One is an oncologist who's a cancer specialist, and one is a colorectal surgeon. This is the person who can take the cancer out and hook everything back together again, okay? And a good colorectal surgeon is worth their weight in gold. They do tremendous, remarkable things through actually really small incisions. So a lot of people are worried about getting a colonoscopy because they jump 10 or 12 steps and they think, gosh, what if I need a bag, right? right? So that is such a small percentage of people that actually need it. Even if you have colon cancer, a lot of times the surgeon can take the cancer out and hook everything back together again. So you wake up with some bandages and that's it, and you go home. I think the shortest time I ever saw, I had a lady who had colon cancer, and she went in the hospital 3 days later, and she was out of the hospital 2 days after that. So it was really a quick turnaround. So literally, she got diagnosed and cured in the same week. So that's something to think about. So the majority of cancers are curable. The majority of, not polyps now, I'm talking about cancer, the big C. The majority of colon cancers that we find are actually curable. But the statistics I said when we first started, about 50,000 people dying from colon cancer, that's a real number, and that number has to come down. That's the way I look, okay? So don't wait, get your appointments and get lined up and get screened so we don't have to have that discussion, okay? So we talked about prevention a little bit. The best way to prevent it is to find polyps and take them out. Hands down, we know that's a fact. If you have polyps, get them out and prevent them from ever turning into cancer. That's the best way to prevent you from ever getting and dying from colon cancer, okay? That's the deal we make with you. If you come in for your test and you hit your regular screening intervals, you scratch colon cancer off your list of things to worry about, okay? So screening routine and regular intervals, that's the best thing to do, okay? It saves lives and it prevents cancer. I don't know how much more black and white I can tell you. That's the truth. But what can you do at home? And a lot of people want to know, like, well, how can I prevent polyps, or how can I prevent this or that or the other thing? This is not news, but you got to quit smoking. Okay, smoking is the devil. All right, it causes all kinds of problems. It causes heart disease, strokes, kidney disease, and all cancers. If you look at risk factors for all cancers, smoking is on every single list. So it's an extremely hard habit to break. But again, that's something you can do at home to lower your risk for so many diseases. The other thing is weight loss. So like other diseases like diabetes, high blood pressure, cholesterol, heart disease, cancer is also on that list of risks who people are carrying too much weight around. So we really have a discussion with our folks that come into the office about nutrition. And that's an uncomfortable discussion to have as well. But a lot of people need to see nutritionists, need to learn how to look at their food plans and their diet regimens and things like that. Get the body moving, start exercising. Doesn't matter if you're 26 or 86, get the body moving, get those joints fluid and get the exercise going, because that will help as well. Now, we talked a little bit about diet, and I'm not by all means, vegan, naturalist, whatever, anything like that. I mean, I like my donuts just like anybody else does. But as much as you can try to prevent or limit the amount of processed foods or heavily nitrated foods like hot dogs or processed meats, things like that, the better off that you'll be in terms of lowering your risk of colon cancer. And minimize alcohol. So that is also another risk. Now, as far as other diets or supplements or things like that, there's some idea that, a baby aspirin can help, or calcium supplements can help, things like that. These are things that your doctor may tell you to take anyway, because an aspirin could potentially be heart healthy. Calcium is good for those of us as we get older, our bones start to demineralize and we need calcium. That may actually provide some risk. But none of those things, even all of those things together, don't equal the fact that you need to get in and get screened and get your colon cancer screening tests done. That's the big picture here. So if you're 45 or you're older and you haven't had a screening test, whether it be a colonoscopy or a Cologuard test, call your doctor. Probably not in right now, but call them later, or call them tomorrow and say, listen, I want to get screened. Am I eligible? Yes, I want to get screened. Put me on a list and get screened, okay? If you have a family history, bring that up with your physician and say, here's my family history. When do I need to come in to get screened for a colonoscopy, okay? So if a grandmother had it when they're in their 90s, you can come in when you're 45. But if your dad had it when he was 50, we'll see you when you're hit 40, okay? So again, colonoscopy is the preferred screening tool because we can actually see the whole colon and do something about little polyps we find regardless of their size. But a Cologuard is an excellent second choice, as is a FIT test, okay? But remember, stick with the right intervals too. And I can't tell you how many people come in and say, oh, I had my colonoscopy with you. It's only been about 3 or 4 years. And I look back and I was like, it was 2009. So it was actually 12 years ago. I know you want to make it think like it was that long, but it's time to get one done again. And above all else, do everything you can do in your power to stay healthy, okay? Because you're here for a reason. I truly believe that. And that's all that I have to say.
Very good. Oh
So,
awesome.
Thank you.
Awesome.
oh my goodness, thank you.
Wow.
I am
Are
so
there any more questions? Are there any more questions? Anybody have any more questions? Those that have the phone, you want to put your phone on *6. Are there any more questions?
I had another one. I'm sorry, I'm asking a lot of questions.
okay.
But I just wanted to know, why are there different preps? Like, say, Evangelist Sandra may have one prep and I may have another. Like, I might just have pills. Somebody else may have powders. Why are there different preps for this colonoscopy?
Well, I think what you're seeing is, the fact that we're out here screaming for people to get a colonoscopy. And so literally that's, millions of colonoscopies every year across the United States, right? A lot of people are getting them. So these pharmaceutical companies see this and they're like, oh boy, here's an opportunity. And the oldest one is that big gallon of bay water they call Go Lightly or Co-Light or New Light. You may have heard of that one. And that's the one that people equate with what being the most unpleasant one, because it's a gallon, it's salty, it doesn't taste great. And apart from that, it makes you go to the bathroom, countless number of times. They all do, but that's just kind of the insult to injury with that. And that's the prep that people hate because it's really doesn't taste good. So these pharmaceutical companies all got together and said, well, let's make a better prep. Let's make a small prep. Let's make a small volume. Let's make it into a pill form. Let's make it taste better, that kind of thing. And I think one of the funniest things is I was walking back here maybe about 10 years ago or so, and there was a brand new pharmaceutical rep and he's sitting there and so I said, what are you selling today? And he says, well, I'm selling a bowel prep. And he had a glass, about an 8-ounce glass sitting on the table in front of him that was full. And he said, this is the prep, taste it. It tastes good. And I said, you taste it. You go first. And he's like, no, I'm not allowed to do that. My company said, your company's not here and there's no cameras in here. I want to see you taste that before I taste it, because I know what it's going to do to you and I know what it's going to do to me, but I want to see you taste it. And he wouldn't taste it. So I don't use it. I don't know what it tastes like, but God forbid, if that kid wasn't going to drink it, I wasn't going to give it to my patients. But at the same time, the biggest thing, the biggest determinant that I have for people is I don't want it to cost a lot. Some of these preps are not covered by various insurance plans, so that when they get to the pharmacy, it may be a small volume prep. It may be 2 glasses instead of, a gallon jug, but it costs $300. And I totally refuse to do that to people. So I tell people, if they want a smaller volume prep, if you go to the pharmacy and they don't cover it, don't pay for it. Call me and we'll get something else. Now, some offices actually may have samples or copay cards or things like that. So always ask, do you have any, do you have a smaller volume prep or one that supposedly tastes better? And do you have a card, or is there some way I can get it for less expensive if it's not covered by my plan? So that's a long-winded answer to your question. So, but most of them work actually really, really well.
I have a question. Is colon cancer more prevalent in women or men?
Well, here's the interesting thing about that. It depends on the ethnicity. So in African Americans, it's equal.
Oh, wow.
But in white or Asians, it's actually different. Women are a little bit less likely than men. And no one's been able to really fully explain that. But I think rather than explain it, let's get everybody in and get you checked and make sure it doesn't happen. But yeah, that's a great question.
I have a question. Is there a reason why a gastroenterologist would say, like, if you go to them with symptoms, and then would they say, or well, you don't need a colonoscopy? Like, are there maybe there are other tests or other reasons that could be, I guess that might explain what is going on, and they would deny, let's say, a colonoscopy?
Yeah, there potentially could be. But you know, it's such a safe test, and it's a comfortable test that I generally have a very low threshold to suggest that test. And I always think about this lady Donna who's on the local commercials.
Yeah.
She had very vague symptoms, and I remember the first clue is that when I had her in the pre-op area and I was talking to her, I looked at her labs and she was really anemic, and I thought that's not meshing with what she came in with, you know what I mean? So if you come in and you have these symptoms and it's a concern, don't be shy. Say, listen, you know what? I have these concerns and I want to make sure I don't have colon cancer. And it doesn't run in my family, but I don't want to be the person that my family says now it runs in my family because of my mom, my sister, my aunt, that kind of thing, right? So some people may come in with, you know, other symptoms, like they may have pain or something else, and they may suggest, you know, a CAT scan or an ultrasound or blood work or things like that. But if there's not a clear answer to your question or a clear diagnosis to your problem, then yeah, I tell people, listen, we're going to keep going until we find something.
Okay.
I have a question. What causes it?
What causes cancer?
Yeah.
Colon cancer?
Yeah.
You know, that's a question that, you know, we know what some risk factors are, but some people come in and they, you know, I'll go back to Miss Donna, the lady in the commercial. She had 0 risk factors, none. There was no
Because
what's that?
What you said earlier, which is known, more African American has it, than any other, and what the other group is, African American and whoever, but I know more than the white.
Yes.
Why?
And that's a great question. And I think part of it, you know, there's no known genetic predisposition based on ethnic background, whether it's African American or Latino or Asian or white. There's no known genetic predisposition. So we have to think along the lines of, are folks getting the message out that they need to be screened or they should be brought in to be screened? And I think that's a big part of it. I really do. So I think that, you know, vulnerable populations in inner cities and people that have limited access to healthcare, and even people who don't have limited access to healthcare, we need to screen everybody. We need to make sure that people come in to be screened. One of my partners, and I thought this was just a great idea, up in above Camden County, there's a county called Willingboro, Burlington County. And he spent multiple Saturdays before the pandemic hit, multiple Saturdays going to barbershops and talking to African-American men about colon cancer screening, and sitting in the barbershop and talking to anybody that had questions about it. And he did that. He's done that for, honestly, he's done that for years. And I am sure he has saved countless lives up there from just getting the message out and talking to people who may not actually have that discussion brought up by their family doctor, or they may not go to the doctor because they're feeling well, right? And I think that just was such a cool idea to get people into his office to be screened. Something that when the pandemic lifts, we've talked about with all our fellows, going into Camden itself and talking to people in areas that have limited access to screening, or maybe haven't been to the doctor, or maybe have been to the doctor and the doctor hasn't said to them, you know what, you need to get this done. I think that's a big part of it.
Thank you.
Absolutely.